let's put the pretty picture on. So good afternoon, everybody. It's a great pleasure and honor to be invited today to chair this session by Dr. Zeenat Murad, who is well known to everyone and becoming better and better known as she takes her place in leading the community. Zeenat's going to talk to us today about the role of antibody treatment in follicular lymphoma, and I think it's a very exciting area. And what we've seen over the last couple of decades from, sort of really quite toxic therapies with relatively poor outcomes and long-term toxicities, short and long-term toxicities, now becoming an exciting field of targeted therapies, not just with antibodies, but also, and I don't think Zeenat's going to talk about it today, but also pathway inhibitors, etc. Will you do the next slide for me, please? So we are fortunate and grateful to be sponsored by Roche today. The sponsorships are very important in these education programs, and as I think everybody will know, that we've had a very good turnout. I mean, this is something that started in COVID, and the turnout has become shall we say, stable, regular and stable, with a very good turnout, usually in the region of 80 to 100 people. So I think that, thank you to Roche and to Blood SA. I think that's the next slide, for their support of this education program. And we have our intrepid leader, Professor Estelle Verberg, who has kept Blood SA, brought it to life and kept it on the forefront, and her trusty sidekicks, Khadin and Nicole, who do a lot of the heavy lifting and making sure that these things work as smoothly as they do. Thank you. Next slide, please. So as you know by now, because most of you are regulars, is that the recordings the sessions are recorded and you can get back to them. You must please feel free to make your comments and questions in the chat box. There will be a question answer session at the end, but if your question's in the chat box, then I will coordinate it. Otherwise, we will give you an opportunity at the end. And this next slide, please. The CPD points that work very well. You register with your HPCSA number, and as long as you are here for the hour, you will get your point. And if you have any problems or anything, here's the email address to talk to somebody, admin@bloodsa.org. You can join the website, the mailing list, and make sure that you're on these systems, but I'm assuming if you're here today that you're already on the mailing system. Next, please. I think we are ready to start. So just one more thing is the next talk will be the 2nd of February, 2026. So 2 months time. It remains for us to wish everybody the best wishes for the end of the year and the holiday season, and all the best for a productive and peaceful 2026. I think it's now Zeenat's turn to talk. Yeah, we already talked about this. So if we can load Zeenat's slides. And we didn't actually get a CV on you, but Zeenat's now in private practice, full-time private practice in KZN in Durban, and there we are. And following up on her initial very high summa cum laude graduation and qualification, and now moving into, as I mentioned earlier, the leadership role that we like to see. And who can criticize anybody who loves chocolate?
I agree.
Okay. And with that, we hand over. We are already at 80 people and
We have the
5 minutes past, so let's load Zinat's talk, and I'm sure the other 20 will join in a moment.
Nicole, you have the talk.
Zenit, I don't have it on my side. Did you email it to me?
Yes, Roche sent it to you.
Let me double check.
Because I had to submit it to them. Oh, there we go. Okay, so good afternoon,
Thank you,
everybody.
Nicole.
Thank you so much, Nicole. You're always a lifesaver. Thank you for inviting me to be the last speaker of the year. Today's talk, as David said, it's quite an exciting era to be in hematology, as we know that patients with follicular lymphoma, well, to us, we find that they're quite a challenging cohort of patients to treat, and we often struggle to keep them in a remission, and we run out of options very quickly, depending on medical aid schemes, etc. So today's talk is called From Chemotherapy to Bispecific Antibodies, and we are redefining follicular lymphoma treatment paradigms. This is my disclaimer. And then the talk outline will basically cover the unmet needs and treatment landscape in follicular lymphoma. We'll do an introduction to mosunetuzumab, and then we will cover mosunetuzumab in third and fourth line follicular lymphoma. So in discussing the unmet needs and treatment landscapes in follicular lymphoma, it's important to realize the historical perspective and where we came from. As David said, we came from very toxic chemotherapy based treatments. And in 1997, rituximab was approved for treatment of relapsed refractory follicular lymphoma. Again, in 1998, we were using the CD20 monoclonal antibody. In 2004, in the first-line treatment of follicular lymphoma was the introduction of rituximab with chemotherapy. And then 2 years later, in 2006, we looked at rituximab maintenance in relapsed refractory follicular lymphoma and R-chemo in first-line follicular lymphoma. Again, for a long period of time, it was quite stagnant. In 2010, again, re-looking at R maintenance back in 2011. And then in 2014, that was the first major sort of breakthrough in third line and relapsed refractory follicular lymphoma, looking at idelalisib. In 2016, the introduction of obinutuzumab and bendamustine in relapsed refractory follicular lymphoma. And then in 2017, again, looking at obinutuzumab with other chemotherapy-based treatment backbones. So we know that early disease progression in follicular lymphoma is often associated with an extremely poor prognosis, and that up to 27% of patients with follicular lymphoma have refractory disease or early relapse after initial treatment with an anti-CD20 antibody plus chemotherapy. And when you look at the overall survival by the progression of disease within 24 months, and this is the graph that shows you that the 2-year overall survival is 68%, and the 5-year overall survival in this population is 50%. And this was done at a median follow-up of survival at 7 years. So we know that rituximab and lenalidomide is an effective treatment option for relapsed refractory follicular lymphoma in the second-line setting and further. And this phase 3 augment study of R-Len versus rituximab monotherapy in rituximab-sensitive relapsed and refractory indolent non-Hodgkin's lymphoma, and in this cohort of patients, 82% of them had follicular lymphoma, with the baseline characteristics in 65 of them having an ECOG performance status of 0. In the R-Len group, in the R monotherapy group, there were 71 patients with a performance status of 0. When you look at the FLIPI index, there was high-risk disease in 39 patients who received R-Len, 30 who received R monotherapy, and looking at in their refractoriness to their last therapy, 17% 17 who received R-Len and 14 who had R monotherapy were included in the trial. And again, prior therapies, so 25 and 23 respectively had more than or equal to 3 prior therapies. And looking at the tumor burden per the Gulf criteria, 54 and 48 had a high tumor burden. So we knew that we can see from this trial that R-Len is superior versus rituximab monotherapy, but we can also see that most patients will relapse. So again, taking you back to 2017, where we were looking at obinutuzumab and chemotherapy. And then the emergence of T-cell engaging therapies arose for the treatment of relapsed refractory follicular lymphoma. So in 2019, there was FDA approval for R-Len, EMA approval for R-Len as well. And in 2020, the use of tazemetostat was attempted. In 2021, axicabtagene ciloleucel, so that's part of the CAR T therapies, in third-line relapsed refractory follicular lymphomas. In 2022, again, axi-cel in fourth-line relapsed refractory follicular lymphoma, mosunetuzumab in third-line refractory relapsed follicular lymphoma, and tisagenlecleucel, again, EMA approved for third-line relapsed refractory follicular lymphoma. And the tisa-cel, as well as mosunetuzumab, was also FDA approved in 2022 for the treatment of relapsed refractory follicular lymphoma. Going further along the timeline, the use of the BTK inhibitors, so particularly zanubrutinib and obinutuzumab, was EMA approved in third-line treatment. In 2024, odronextamab, which is also a CD20 monoclonal antibody, and epcoritamab, which is, again, was EMA approved for third-line relapsed refractory follicular lymphoma. And this particular molecule is something which we've had quite a bit of experience, having about 15 patients on a compassionate basis program. So we've seen varied results with this. In 2024, Lysocell and again zanubrutinib and obinutuzumab, as well as epcoritamab, was FDA approved for the treatment of relapsed refractory follicular lymphoma in the third-line setting. And in 2025, Lysocell and tafistamab R-Len. So tafistamab, which we'll speak about, is a CD19 monoclonal antibody. So in treating, before getting to the relapsed refractory statement, there are people at all levels here. So just in understanding the investigation and the workup for patients with follicular lymphoma, it's imperative that all patients have a bone marrow biopsy to confirm the histology. A CT scan can be used, so a staging CT, neck, chest, abdomen, and pelvis. Ideally, you'd want to use a PET CT scan because the PET scan can upstage. So if a patient is an advanced stage follicular lymphoma, you'd want to exclude diffuse large B cell. We would do our basic blood tests, our full blood counts, and our blood chemistries, kidney function, liver function, including the LDH and the beta-2 microglobulin. We do full viral screens, including HIV, hepatitis B, and hepatitis C. Take a thorough history from the patient regarding B symptoms, and then a complete physical examination and looking for comorbidities, so exclude any sort of cardiotoxic or cardiac comorbidities or lung toxicities, including a creatinine clearance and an ECG. So patients are then staged according to the Ann Arbor staging criteria, localized stages, stages 1 and 2, advanced stages defined as stage 3 and 4, and then looking at this symptomatic or high tumor burden, and then the asymptomatic patients. So therapy, depending on localized or early stages, could either be radiotherapy plus minus rituximab, active surveillance, or R monotherapy. In advanced stages, again, we would continue to do active surveillance. If the patient was asymptomatic, possibly R monotherapy. But where patients have a high tumor burden and are quite symptomatic, we would first line go for immunochemotherapy. So either rituximab or obinutuzumab with bendamustine, or with CHOP chemotherapy, or with cyclovink and prednisone. And then obviously we would consider antibody maintenance. So rituximab maintenance every 3 months for about 2 years. In selected cases, patients may benefit from rituximab and lenalidomide. So the treatment options that are recommended in the ESMO 2021 guidelines are based on the different trials. And this is recommended treatment options for relapsed refractory follicular lymphoma. So the AUGMENT trial, which was a phase 3B in rituximab sensitive patients in indolent non-Hodgkin's lymphoma, had 295 patients, and it looked at rituximab and lenalidomide versus rituximab monotherapy. In the R-Len arm, there were 147 patients. In the R monotherapy arm, 148 patients. And it looked at the overall response rate, which was about 80% in R-Len versus 55% in R monotherapy, with a complete remission of 35% in R-Len and 20% with R monotherapy. The median progression-free survival was 39.4 in the R-Len arm versus 13.9 in the R monotherapy arm. And looking at the most common overall adverse effects, in R-Len it was neutropenia in 58% of patients, diarrhea in 31%, constipation in about 26%. And in 9 patients in the R-Len arm, the adverse events led to medication discontinuation. In our monotherapy arm, the patients had diarrhea, about 23%, as well as neutropenia in 22% and fatigue in 18%. And here, 5 patients discontinued treatment. The MAGNIFY arm trial, which was a phase 3B, again in relapsed refractory indolent non-Hodgkin's lymphoma, looked at your R-Len and Len maintenance versus R maintenance. And there were 318 patients here. And the commonest side effects was fatigue, neutropenia, and diarrhea, as you can see, 47, 43, and 37%, with 14% discontinuing treatment here. But 72% of patients had an overall response rate, 42% a complete response, and there was a 51.1 month median progression-free survival. The GADOLIN trial, which was a phase 3 trial as well, looked at obinutuzumab bendamustine versus benda alone. 335 patients were recruited for this trial. Obinutuzumab benda, there were 68% overall response rate, 9% complete response rate, and again, in this arm, there were a lot of infusion-related reactions. So 63%, 52% of patients had nausea, 40% fatigue, 38% neutropenia, and 20% leading to discontinuation. The DELTA trial, which was a phase 2 trial, used idelalisib. There were 72 patients in this trial. 56% of them had an overall response rate, 17% a complete response. There was an 11-month progression-free survival and an 80% 1-year overall survival. Again, diarrhea being the most commonest side effect. Idelalisib is a PI3 kinase inhibitor, so 43% had diarrhea, 30% had nausea, 30% had fatigue, and the most number of treatment discontinuations in the DELTA trial with idelalisib. So what are the recently approved treatments for relapsed refractory follicular lymphoma? And these have been approved from about 2022 to 2025, so quite recent. Mosunetuzumab in the G029781 trial. 90 patients with follicular lymphoma were involved in this trial. with an overall response rate of 80% and a complete response rate of 60%. And that was an independent reviewer committee assessed response rate, as well as an investigator assessed response rate of 78% with an overall response and 60% with the complete response, with the median progression-free survival of 24 months. And the adverse effects of clinical interest here are the cytokine release syndrome, which we'll speak about in 44% of patients, but only 2% experienced a severe or a grade 3 or 4 reaction. Neutropenia, 29%. Again, 27% experiencing a grade 3 or 4 reaction. And then your immune effector cytotoxic associated neurotoxicity like adverse effects in 6% of the population. So axi-cell, T-cell, and lysocell are the CAR T cells. So the ZUMA-5, ELARA, and the TRANSCEND trials, which recruited about 124, 97, and 130 patients with follicular lymphoma. And again, showing quite a marked overall response rate. So 94% for axi-cell with a 79% complete response rate. And then investigator assessed 95% and 80%. And again, with the CAR T therapies, we see that cytokine release syndrome is featuring as the major side effect or adverse effect. But with axi-cell, there was a 6% that had more than and equal to a grade 3 adverse event. So that's quite serious. And then ICANS was not present in any, so it was 0. With the T-cell, again, 49% with CRS. And then with the lysocell, 58%. When looking at the Rosewood trial using zanubrutinib and obinutuzumab, 145 patients were involved in that, and 69% had an overall response rate, 39% had a complete response rate, and 68% with an overall response rate that was investigator assessed, with a 28-month median progression-free survival. And with the BTK and the CD20, we found that infections are quite high at 55%, bleeding in about 28%, and atrial fibrillation 3%. And we know that bleeding and atrial fibrillation can be associated with the BTKI inhibitors. Epcoritamab was used in the EPCOR non-Hodgkin's lymphoma 1 trial with 128 patients. 82% of them had an overall response rate. 63% had a complete remission rate. Again, a 15.4 median progression-free survival in months, and then also featuring CRS of 49% and ICANS of 0%. But again, the side effects of the CRS were grade 1 and grade 2 and not any more than grade 3. Odronextamab was in the ELM2 trial, so 128 patients with follicular lymphoma were recruited here. There was an 80% overall response rate with a 73% complete response rate, and again 82 and 3 via investigator assessed methods, with a 20.7-month median progression-free survival. So 56% of patients here had cytokine release syndrome, and grade 3 was present in more than 1.7, neutropenia in 39%, and pyrexia in 38%. And then tafasitamab, which is a CD19 monoclonal antibody, with len and rituximab in the InMind trial. 273 patients with follicular lymphoma were involved in this trial, and the investigator-assessed response rate was 84%, with a complete response of 52%, and a median progression-free survival of 22.4 months. Again, neutropenia at 49%, with 40% having quite a severe neutropenia, so grade 3 or 4, diarrhea in 38%, and pneumonia as the infective mechanism in grade 3 or 4. So the NCCN clinical practice guidelines in oncology for second-line follicular lymphoma have certain preferred regimens. So there are certain that are preferred for younger patients, others for elderly or infirm patients, and then just other recommended regimens. So when treating a patient for second-line follicular lymphoma, the options would be bendamustine plus obinutuzumab or rituximab. So that's bendamustine with the CD20 monoclonal antibody. But it's not recommended if the patient has been treated with prior bendamustine. We know that bendamustine is quite a profound T-cell depleting agent. CHOP with obinutuzumab or rituximab, CVP plus obinutuzumab or rituximab, lenalidomide and rituximab, tafasitamab and lenalidomide and rituximab. And this is in patients with more than or equal to one prior systemic therapy, including an anti-CD20 monoclonal antibody. For the elderly or infirm patients, if none of the other therapies is expected to be tolerable in the opinion of the treating physician, you could use rituximab 375 milligrams per meter squared weekly for 4 doses, or tazemetostat, irrespective of the EZH2 mutation status. So that's, I think, where it's available. And then other recommended regimens would be cyclophosphamide plus minus rituximab. And in general, the other regimens would be lenalidomide if a patient is not a candidate for an anti-CD20 monoclonal antibody therapy, len plus obinutuzumab, obinutuzumab alone, or rituximab alone. There is extended second-line therapy, which is also optional. So the preferred regimen, according to the NCCN clinical practice guideline, is rituximab maintenance. Again, 375 milligrams per meter squared, 1 dose every 12 weeks for 2 years. That's a category 1 recommendation. And then obinutuzumab maintenance for rituximab refractory disease. And that's 1 gram every 8 weeks, or 2 months, for a total of 12 doses. And then again, an optional second-line consolidation therapy with high-dose therapy with autologous stem cell rescue or stem cell transplantation. The NCCN guidelines for patients who are in the third-line setting with relapsed refractory lymphoma, and this is version 2 of 2025. So for third-line and subsequent therapy, the preferred regimens are that of T-cell engager therapy. So again, using either bispecific antibody therapies like epcoritamab or mosunetuzumab, or where available, CAR T-cell therapy such as axicabtagene ciloleucel, which is CD19 directed, or lisocabtagene maraleucel, which is also CD19 directed, and the last CD19 directed therapy is tisagenlecleucel. Other recommended regimens are your EZH2 inhibitor, so that's tazemetostat, again irrespective of the EZH2 mutation status, BTKI inhibitors, so zanubrutinib and obinutuzumab, and then loncastuximab tesirine plus rituximab, and this is an antibody drug conjugate. And then the third-line consolidation therapy, which is useful in certain circumstances, would be allogeneic hematopoietic stem cell transplantation. So the ESMO, or the EHA treatment algorithm from 2021, recommends treatment algorithms for patients looking at their tumor burden. So if a patient had a high tumor burden and they had a first relapse or progression after the first line of therapy, and if you looked at their age and if they are younger than 65 years, we would consider immunochemotherapy. And if the patient had a complete response or a good partial response, we would discuss antibody maintenance. In selected cases, you could use rituximab alone, autologous stem cell transplant in patients who've had early relapses or had disease transformation from follicular lymphoma to high-grade lymphoma, and then again using our rituximab and lenalidomide in patients with early relapses. If there were long prior remissions, patients could get immunochemotherapy or R-Len, and again in selected cases, autologous stem cell transplant, radioimmunotherapy, idelalisib in double refractory patients, and allogeneic stem cell transplant. For patients who have a first relapse but are older, so more than 65 years of age, you could consider immunotherapy, immunochemotherapy, and then again antibody maintenance, looking at rituximab, radioimmunotherapy, or R-Len. And again, with later relapse or progression, similarly, you'd consider R-Len, R immunochemotherapy, if there were long prior remissions, and in selected cases, radioimmunotherapy with idelalisib and allogeneic stem cell transplant. So, as an introduction to mosunetuzumab, we're going to discuss the mode of action of the drug, of the molecule, looking at the preclinical activity, the dosing, and then the approvals, the EMA and the FDA approvals. So we know that there are strategies to harness T-cell activity in non-Hodgkin's lymphoma, which have proved very effective in treating even the high-grade lymphomas and other indolents. And there are two main classes of T-cell engaging therapy that are currently under investigation in both diffuse large B-cell lymphoma and follicular lymphoma. The first is the CAR T therapy, or chimeric antigen receptor T-cell therapy, and the second is your bispecific antibody therapies. So these may be either fragment-based without an FC, so the FC is the fragment crystallizable region. So those are, for example, the first type is your BiTE or your bispecific T-cell engagers that do not have an FC region. And then you have the second category of those that do have an FC or a fragment crystallizable region. And bispecific antibody therapy has proven to be a promising approach for non-Hodgkin's lymphoma treatment. We know that bispecific antibodies can recognize and bind simultaneously to two different antigens on the same cell, or on different cells, or even to two different epitopes on a single target antigen. So these are the approaches the possible approaches with the bispecific antibodies. You can see in the first diagram that this molecule is targeting two antigens on the same tumor cell. In the middle diagram, the molecule is targeting two antigens on different cells. So one is a tumor cell and one is a T cell. And then in the third example, the molecule is targeting two epitopes on a single target protein. So there's multiple approaches. And the middle type, where there's targeting two antigens on different cells, is the mechanism of the current bispecific antibodies under investigation in non-Hodgkin's lymphoma, and they are targeting two cell surface antigens on different cells. So one cell is the CD20 positive malignant B cell, and the other cell is the cytotoxic T cell, and that's binding to CD3. So the anti-CD20, anti-CD3 bispecific therapies create an immunological synapse between T cells and thereby target B cells. So there is concomitant binding to CD3 and CD20, and it's CD3 epsilon, which is a component of the T cell receptor complex on the surface of T cells, and to CD20 on the surface of B cells. This synapse formation allows the engagement of both arms of the bispecific. So binding of the CD3 epsilon and the CD20 results in cross-linking of the T cell receptor and formation of an immunological synapse. T cells are then activated, leading to B cell killing, cytokine release, and T cell proliferation. So you can see that there's a T cell binding site, which is the yellow, and the B cell or the CD20 binding site in this immunological synapse. So mosunetuzumab is a full-length humanized IgG1 bispecific antibody that targets both CD3 and CD20. The CD3 antigen binding site that mosunetuzumab binds to is CD3 epsilon, which is, like I said, is a component of the T cell receptor complex on the surface of T cells. There is an Fab region, or the fragment antibody binding region, and here in this antigen binding domain, it contains two distinct antigen binding sites, which allows the selective and concomitant binding to CD3 on T cells and CD20 on B cells, redirecting endogenous nonspecific T cells to engage and thereby eliminate malignant B cells. The CD20 antigen binding site is expressed on the surface of B cells. And then there's an engineered FC region. So mosunetuzumab has this full-length antibody structure incorporating the FC region, which confers a longer half-life versus the bispecific T-cell engagers. And it also has an N297G amino acid substitution in the FC region that prevents the activation of antibody-dependent cell-mediated cytotoxicity. So those are the differences when comparing to the T-cell engager therapies. So like I said, it redirects endogenous nonspecific T cells to engage and eliminate malignant B cells. It's a very important mechanism of action. The T cell activation occurs via signaling events triggered by T cell receptor binding, leading to the secretion of granzymes and perforins and subsequent T-cell dependent target cell death, the T cells also undergo proliferation and expansion at the tumor site and allow this activity to be enhanced. So we know that mosunetuzumab is therefore highly active in depleting malignant B cells, and this was shown in humanized mice, where there was a potent reduction of B cells in the peripheral blood at day 7. And when it was the mice were studied again, there were almost no B cells detected at day 21 in the blood or the spleen. So therefore highly effective at eradicating malignant B cells. It also has broad activity against normal and malignant B cells expressing CD20. So when looking at lymphoma cell lines and healthy B cell, donor B cells, there's a killing value that was measured. So when it was tested in dose response assays across a panel of 7 B cell lymphoma cell lines with various levels of CD20 expression, you could see it had a broad activity. And when it was tested in response assays across peripheral blood mononuclear cells isolated from healthy donors as well. So it has a mean EC50 value for B cell killing of less than 3 nanograms per mil, and a mean extent of killing was approximately 85% after 24 hours in culture. So mosunetuzumab can achieve efficient B cell killing at very low effector to target ratios. It is able to kill B cells at effector to target ratios, so that's looking at CD8 T cells to CD20 positive B cells, as low as 1:18. And this was taken from 2 different CLL patients to show this low effector target ratios that are required for its activity. T-cell activation by mosunetuzumab requires the presence of CD20 positive B cells. So depletion of CD3 positive T cells from your peripheral blood mononuclear cells abolished the activity of mosunetuzumab. And T-cell activation by mosunetuzumab was strictly dependent on the presence of CD20 positive target B cells. Mosunetuzumab activated purified CD4 positive and CD8 positive effector T cells with comparable potency. So this is how it enhances T cell activity. So when looking at the IV clinical dosing regimen and the rationale, we know that with the antibody therapies, each one is quite different. Mosunetuzumab requires step-up doses similar to the others. So 1 milligram of it is administered on cycle 1 and day 1, and then 2 milligrams on cycle 1, day 8, so 7 days later. And this is the step-up or the ramp-up for this, and it enhances safety. It shows a clinically active and manageable safety profile, and it's been empirically determined with a low risk of cytokine release syndrome. So we know with the antibody therapies that if you start off at a high dose, they're going to have a cytokine release, especially depending on the disease bulk or the tumor load. So this step-up dosing regimen was supported by pharmacological modeling and clinical exposure response data for safety. To maximize efficacy of the drug, there are loading doses which are then administered. So 60 milligrams on cycle 1, day 15, and cycle 2, day 1. And this allows rapid debulking to maximize efficacy in patients with a higher tumor burden. It also allows earlier onset of target engagement for patients with residual anti-CD20 from prior therapies. And then you have the base doses, which are basically 30 milligram doses given from cycle 3, day 1 onwards every 3 weeks. And these allow for durable responses and long-term safety. They maximize efficacy following initial tumor debulking. They maintain this durable clinical response, and they minimize unnecessary overexposure and the potential for long-term cumulative safety risks. So the initial step up for the 2 doses, then 2 loading doses, and then every 3 weeks, 60 milligrams. So it is administered as a fixed duration regimen. Mosunetuzumab is administered for 8 cycles unless there is unacceptable toxicity or disease progression. And cycle 1, day 1 and day 8, I give day 1 1 milligram, day 8 2 milligrams. It's administered intravenously over a minimum of 4 hours, so that they have to be done slowly. After 8 cycles, if patients have achieved a complete remission, there will be no further treatment required. Or if there is a partial remission or stable disease, you could use an additional 9 cycles of mosunetuzumab that should be administered. And if infusions were well tolerated in cycle 1, subsequent infusions may be administered over 2 hours. So as long as there was no severe adverse effects, you could decrease the the time of administration to 2 hours instead of 4 hours. So looking at the G029781 with mosunetuzumab monotherapy in third-line follicular lymphoma, this was a phase 2 expansion of mosunetuzumab. It was a single-arm, multi-center phase 2 expansion in patients with relapsed refractory follicular lymphoma and more than and equal to 2 prior therapies. Patients who were eligible had to be either grade 1 to 3A follicular lymphoma with an ECOG performance status of 0 to 1. They had to be relapsed or refractory to more than 2 prior regimens, including more than and equal to 1 anti-CD20 antibody and more than and equal to 1 alkylating agent. And the endpoints were looking at an independent reviewer assessed complete remission as a best response, and then a whole range of other responses, a secondary endpoint, so overall response rate, the duration of response, the duration of a complete response, progression-free survival, overall survival, and then the safety. So mosunetuzumab administration was given 3 weekly IVI. 8 cycles were administered if the patients achieved a complete remission after cycle 8, but 17 cycles if there was only partial response or stable disease after cycle 8. And again, fixed duration therapy, step-up dosing for the CRS mitigation. With this group, retreatment with mosunetuzumab was permitted if patients relapsed after they had discontinued. So if they had previously achieved a CR but then had relapsed, they were allowed to be retreated with it. And the important thing here was that hospitalization was not mandatory for these patients. Right, so 90 patients, of which the median age was 60, ranging from 29 to 90. 55 of the patients were male. Performance status of 0 in 53 of the 90 patients. 37 of them had an ECOG performance status of 1. 21 patients with an Ann Arbor stage of 1 or 2. Majority, so 69 with advanced disease, 3 or 4. The median lines of prior therapy was 3. So these patients had 3 prior lines of therapy. 28 of the 90 had a prior autologous stem cell transplant. 62 were refractory to the last prior therapy. 71 refractory to any prior anti-CD20 therapy. 47 had progression of disease in 24 months. And 48 patients were double refractory to prior anti-CD20 and alkylator therapy. And when looking at the response rate, the time to first response with the median range was about 1.4 months, and that ranged from 1 to 11 months. And the time to first complete response was 3 months, again ranging from 1 to 19 months. So it was different depending on whether it was investigator assessed or not markedly. It was quite similar actually, investigator assessed and independent review facility assessed. So 54 for both of them, with just a small difference of the overall response rate between 70 and 72. So the CR rate was significantly greater here than 14% historical control complete remission rate in a similar patient population receiving the pan-class PI3K inhibitor copanlisib. So this was compared to the PI3 kinase inhibitor. And the response rate were comparable in high and low risk groups. So it didn't make much of a difference between them in the different subgroups. The duration of complete response and the progression-free survival with mosunetuzumab versus the last prior therapy. So the graph on the left is looking at the duration of the complete response in the patients, and then the right looking at progression-free survival. And the duration of complete response was not reached in the patients on the mosunetuzumab arm, and the progression-free survival was 24 months. That was the median progression-free survival. So an extended duration of complete response and a 12-month improvement in median progression-free survival with mosunetuzumab compared to the last prior therapy in these patients. Therefore, you can see that it does induce a prolonged and durable response with a median follow-up of 49.4 months, 2 out of 3 patients, which was 64%, with a complete remission, actually progression-free. And when looking at the progression-free survival and the overall survival with a median follow-up of more than 4 years, you can see that the overall survival actually remained quite high after 4 years of follow-up. So 48-month progression-free survival was 38.6, and the 48-month overall survival, 82.7%, with the progression-free survival being 24, and the median overall survival having not been reached. So mosunetuzumab therefore prolonged survival in patients with a complete response, and with the median follow-up of more than 4 years, nearly all patients with a complete remission are alive. So what are the new anti-lymphoma therapies after mosunetuzumab? So the patients that did progress went on to other options. So any new anti-lymphoma therapy, new systemic treatments, so chemos plus minus immunos, PI3 kinase inhibitors plus minus immunotherapy, CAR T-cell therapy, BTK inhibitors plus minus venetoclax, lenalidomide, and immunotherapy. Some patients had radiotherapy or excision of the tumors, and then 2 each having allogeneic stem cell transplant or autologous stem cell transplant, with a median time to next treatment of about 55.9 months. So like we said earlier, if patients had stopped their 8 cycles and if they had relapsed, they were allowed to be retreated, and the retreatment data are encouraging. And this looks at the response time to first treatment and retreatment, with an interval between the end of initial treatment to the start of retreatment being about 4.8 to 29 months. And of the 5 patients who received retreatment, 4 had a complete response and 1 had stable disease following retreatment for the refractory follicular lymphoma. And then in looking at the durability of response and the survival over time, we can see the median duration of response being the time from first response to therapy, but the duration of complete response, meaning it was the time from the achievement of a complete response. And there's different data cutoff dates. So in August 2021, July 2022, May 2023, and again May 2024. So as of May 2024, there was a median duration of follow-up of 49.4 months, with the median duration of response of 46.4, and then a median duration of complete response of 51.8, with the 30 to 45 month of 64 to 78. So there was a durability of response and survival over time. And there is no association between the timing of a first complete response as well as the duration of response. So the median time to first complete response was 3 months, with the median duration of response not being evaluable in patients with early or late CR. So the baseline characteristics by the response at the end of treatment, patients with a complete response at end of treatment and those without So 63 years of age, that was the median age, 47 of which were female, that had a complete response, 29 without a complete response were female. And then again, looking at the ECOG performance status, the Ann Arbor, the median lines of therapy, the refractoriness to the last prior therapy and anti-CD20 antibodies. Also looking at double refractoriness and progression of disease, as well as patients with prior stem cell transplantation and prior bendamustine therapy. So this, in the interest of time, I'm just going to move on to the safety data, because we know that safety is a big consideration with the bispecifics. So looking at adverse events that were mosunetuzumab related, there's grade 3 or 4 adverse events, serious adverse events, grade 5, which are categorized as fatal adverse events, and adverse events leading to treatment discontinuation. And if you look at the table, it's quite small, but there's a whole range of adverse effects. So cytokine release syndrome is at the top, fatigue, headache, neutropenia, pyrexia, hypophosphatemia, pruritus, hypokalemia, cough, diarrhea, nausea, constipation, dry skin, and rash. And important in this patient cohort is that no new adverse events were reported since the previous data cutoff, and the incidence of adverse events and serious adverse events remains unchanged with extended follow-up of this data. And then if you look at the colors of the blue, you can see grade 1 is the light blue, grade 2 is the slightly darker, and then going into the navy to the quite dark blue is grade 3 or 4. So the advanced or the serious adverse events are not as significant. Cytokine release syndrome, there are 4 grades, so grade 1, 2, 3, or 4, and you can see that grade 3 and 4 was just one patient, so not very common, which is a good thing. The median time to the CRS onset ranged from 5 hours in cycle 1 with the cycle 1 day 1 dose to 27 hours in the cycle 1 day 15 dose. The median duration was about 3 days. The number of patients that required corticosteroids for CRS management were 10, and the patients that required tocilizumab for management of CRS amounted to 7, and 100% of the events did resolve. We can see that 36% of patients, there was a grade 3 adverse event, but that was obviously with the larger doses, so the loading dose of 60 milligram. But CRS was predominantly low grade and occurred during cycle 1. All the CRS events actually resolved, and no new events were reported at the 4-year follow-up, which is basically what we do see with the patients on the bispecifics. Oops. Sorry. Okay, and then looking at the tumor response and cytokine release syndrome occurrence, there is no correlation observed between the occurrence of cytokine release syndrome and a tumor response. Again, looking at the overall response rate in patients who had CRS versus those who didn't, and looking at those that had complete remissions versus those who didn't, as well as looking at the median duration of response and the duration of complete response. There was no correlation between the CRS. Infections. So infections are a massive problem that we do see. Infections and infestations of any grade occurred in 45 patients. Serious infections in about 18. Grade 3 to 4 infections in 15. Grade 5 or fatal infections in 0. And there was one patient where infectious adverse events led to the withdrawal of treatment. So we know that the safety profile in the overall population of mosunetuzumab was consistent with the 3-year follow-up. Over 71.1% of patients received antimicrobial prophylaxis. Of these, 35.6% received Bactrim, and 48.9% received acyclovir, valacyclovir, or some sort of antiviral prophylaxis. Opportunistic infection was reported in one patient with the grade 2 pneumocystis jirovecii pneumonia. And you can see that the most common infections of any grade your unspecified pathogens, so upper respiratory tract infections and urinary tract infections occurred in 8 patients each. Viral infections, so COVID-19 or suspected COVID-19 in 4, herpes zoster in 3, Fungal infections with oral candidiasis and tinea pedis occurred in 2 patients each. Bacterial infections with cellulitis, Klebsiella, and Pyronychia, again occurring in 2 patients each. And then Pneumocystis jirovecii pneumonia in 1 patient. So all infections occurred within 12 months from the last mosunetuzumab dose. The median times to onset of first infection and first serious infection were 54 and 78 days respectively. 95% of all infections resolved. Most of the serious infections, about 73.7%, occurred in the first 4 cycles, and among the 69 patients who received at least 8 cycles of treatment, serious infections were reported in 3 patients after cycle 8, but majority of the serious infections resolved. So that's 19 of the 21. So in conclusion, the pivotal phase 2 G029781 study met its primary endpoint. There was a 60% complete remission rate versus a 14% historic control. Highly durable responses were achieved with more than 4 years, so that's 49.4 months follow-up. The median duration of complete response was 51.8 months. 82.7% of patients were alive at 48 months. Mosunetuzumab had a manageable safety profile and can be administered as an outpatient regimen. Cytokine release syndrome was predominantly low-grade and occurred during cycle 1. Majority of infections were during the first 4 cycles and did not occur during extended follow-up. Pharmacodynamic evaluation supported fixed duration therapy. Deep molecular responses occurred early, and all patients in complete remission had undetectable minimal residual disease at cycle 8. B-cell recovery is detectable at a median of 19 months, along with immunoglobulin recovery after the end of treatment. Fixed duration mosunetuzumab monotherapy achieved complete remissions and prolonged overall survival in heavily pretreated patients with relapsed or refractory follicular lymphoma. So just briefly looking at it in third-line follicular lymphoma, this was where the patient had a progression of disease within 24 months and high-risk features, looking at their lines of therapy and again looking at the age, so the younger versus the older patients. So if you look at patients with POD 24 or non-progression of disease 24 and looking at the baseline characteristics again, there were 60 patients, 63 was the median age in the non-POD 24, 57 in the patients who had progression of disease within 24 months, 55 were male, 24 in the non-POD and 22 in the non-POD and 33 in the POD 24. Again, performance statuses of 0 and 1, Ann Arbor stage 3 or 4, looking at the median lines of therapy, which were 3 in all categories. 62% of patients were refractory to the last line, with more being in the progression of disease of the POD 24 category, that was 36. They were refractory to prior anti-CD20 therapy and double refractory in 48 patients. And what was found regarding the response rate and the duration of response was that there were high and durable response rates achieved, and this was independent or irrespective of the progression of disease status within 24 months. And that there was the overall survival benefit was observed in both, so they had a similar progression-free survival and an overall survival benefit in both the patients with progression of disease within 24 months, as well as those with the non-progression of disease within 24 months. And again, looking at the safety profile of the drug in this in this cohort, the safety profile was actually consistent with the overall safety cohort. So there were some adverse events related to the mosunetuzumab, but again, grade 5 or fatal in 1 patient with progression of disease within 24 and 1 of the non-POD, and then serious adverse events in 21 of either, but patients who had adverse events leading to the discontinuation were mostly in the non-POD regimen, with only 1 in the POD 24. So again, the safety profile was consistent with the overall safety cohort. and some of the adverse effects of interest. So cytokine release syndrome, like we've spoken about, neutropenia, and serious infections that occurred in 18 out of the 20 out of 18 out of the 90, so 20% of the population. And the efficacy and the durability in patients with high risk features were generally consistent with the overall population. So again, looking at the stage, bulky disease, those that had elevated LDH, which is a high risk feature, and then those with double refractory, they still had similar efficacy and durability. And the duration of complete response and progression-free survival with double refractory disease, again, similar progression-free survival and overall survival benefit was observed in patients with double refractory disease. And then looking at third line versus fourth line and more therapy, again, 60 patients in this cohort with similar breakdown of the performance status, stage 3 or 4 disease, median prior lines of therapy, those that are refractory to the last prior therapy or prior anti-CD20 therapy, and those who are double refractory. So you can look, when you're looking at the line of therapy in the third line, 61 was the median age, in the fourth line 59, males, 38 males in the fourth line versus 17 in the third line, and then advanced stage, so stage 3 or 4, 44 out of the 55, so 80% in requiring fourth line therapy. There were more than 4 median lines of prior therapy in those requiring, and then 40 were refractory to the last prior therapy, with 46% being refractory to anti-CD20 therapy and 35 being double refractory. And the median duration of complete response was not reached in third line patients, while it was 33 months in patients who were being treated for fourth line and over. So that's important. And again, higher progression-free survival benefit so overall survival and progression-free survival benefit in patients who received mosunetuzumab in the third line versus the fourth line setting. And then looking at the safety profile, again, when you're comparing third line of therapy versus fourth line plus, the safety profile, again, was quite consistent with the overall safety cohort. And that is the end of my talk. And just to conclude with best wishes for a happy holiday season and a joyous new year. So if there are any questions or comments, we can discuss them now. Thank you.
Thank you very much, Zinat. What a tour de force, but also what an impressive therapy.
Yeah.
Bypasses the drug resistance that we're seeing, and irrespective of whether the patients who are traditionally the very poor prognosis with early progression or have had more than 3 lines of therapy. I mean, that's very impressive. There are no questions on the chat group that I can see. So I encourage the rest of you to start and to get that going. I just wanted to ask you perhaps a few practical questions that perhaps maybe we can start with. In the IgG deficiency, which I think one would expect as you said, there's B cell depletion, and I think any B cell depleting treatment, and also with the patients being so heavily pre-treated, one would expect that. Was there any need to preemptively treat patients with IVIG replacement therapy? Do you also use a cutoff of 4 gram per liter, or do you use the normal range? How do you manage that?
So in our experience using the other bispecifics, infections have been a serious problem. We had a patient who actually passed away from pneumocystis from PCP, and then another one who we treated his lymphoma, but we lost him to CMV infection. So we routinely check immunoglobulin levels, um, and if it is low, so if it's under the 6, we would supplement them. And we find that giving about 12 grams monthly actually maintains their IgG levels and has decreased infections completely. So you have to check immunoglobulin levels. I know when we're looking at epcoritamab, it was saying if it's under 4, you should be replacing. But because we are the bispecifics that we've been using, we've been able to access by a compassionate basis program. We've been able to get the patient's medical aids and things to pay for the polygam therapy, which they have been doing as supportive therapy, and it's changed the way we deal with bispecifics. We don't see infections much now versus when we first started using them about 2 years ago.
So I think you highlight a very important point in these lymphoid malignancies is that these patients are immune compromised, and they're immune compromised in their ability to deal with viral and bacterial infections. And as your talk indicated, also sort of superficial fungal infections as well. So um, there's a question in the chat group, but I'm assuming that pretty much standard is cotrimoxazole and acyclovir prophylaxis. What about CMV? You mentioned that patient, do you just have a high awareness or do you test routinely?
So we do a CMV in patients who have had a previous history of cytomegalovirus infection. We do a monthly CMV viral load on them to watch the trend. We've seen that it can go from 150 to 20,000 in days. So we have to routinely monitor them. And that patient actually had a CMV pneumonitis. So he came in with a chest infection and things, and his viral load just went up to 40,000 and continued to climb. But he was quite resistant, and this is something else that we're seeing now, just across the board is CMV resistant. So we've had just a young boy who was 14 who we transplanted for an acute lymphoblastic leukemia, who was resistant to Valhet, who was resistant to ganciclovir, and we've actually just got him on Foscovir now. So maybe I can use this opportunity to ask the thought on how we could maintain him with a low CMV viral load, because now we're wondering how do we prevent it from increasing again. But we do routinely do monthly CMV viral loads.
Yeah. And also, I think you highlight the point that one should have a high level or index of suspicion. And if you have a pyrexia without a positive bacterial culture or PCP, hepatitis, any diarrheal illness that to look for a raised CMV. How to maintain your patient? You need to get the immune suppression. You need to get them off immune suppression and have their counts recover in that situation. There have been a few questions about cost, and I've looked at the cost online, but the problem is that South Africa often gets some form of preferential pricing. Not that it feels like it when you're trying to pay for it, but I suppose what I would like to ask in that context is, do you know if and when it is going to be licensed, and is there a plan for AICF support?
So I'm not sure about that at the moment. I'm not sure if there's anyone on here from Roche who can
Yeah,
assist with that.
yeah, let me just answer that. Mosan is available. It was registered this year. The issue is we're still working on the pricing in terms of submitting the dossier and getting global pricing. So at this point in time, I don't know the amount it will come with. So yeah, so that's where we are. But by March next year, we should have an idea.
And Michelle, Roche has been very good at trying to keep the costs of drugs down to improve access. I mean, we look at the pricing of Gazyva, which of course has not been, which has not echoed some of the other monoclonals. Are you going to be aiming at that, or are you going to be aiming a bit more at the kind of polatuzumab type of pricing?
So I'm not a market access person. I'm from medical. And
Dodge
I
the
don't
bullet.
want to answer on behalf of market access, but normally when you have price flexibility, it's when you have a patient pool that's a lot. And when we look at the follicular lymphoma stats and the patients that will get third line therapy, the numbers are very small. So that's my answer in a nutshell. So as opposed to diffuse large B cell with Columvi, there was that price flexibility.
I would disagree with that. I think that follicular lymphoma is that tip of the iceberg thing, is that you've got a lot of people with follicular lymphoma that are grumbling along and lurching from one toxic therapy to another. And given the opportunity to use a drug that's as effective as this, there would be a sizable proportion of patients who would be diverted out of chemotherapy, auto stem cell, and maybe even out of allo programs into the treatment. Can I just go back to Dr. Murat and ask, the one set of results seem to indicate that that a lower percentage of females failed therapy. And we know that with rituximab that the volume of distribution and the decay rate of rituximab in males is much higher. Is that similar? Did you come across anything like that with your reading now?
So our patients, interestingly, the ones we've struggled with have been the females. They,
Okay.
yeah, we've had we've lost many of our females with follicular because of. So it's interesting to actually go back and look at that because some of them were overweight. Looking at the volume of distribution, etc.
Okay.
Yeah, that's
And
a
then
question.
um, you just briefly touched on the effect of using drugs like bendamustine and fludarabine in in these patients and the way it is extremely T cell toxic. And is there a preference in terms of ordering the treatment and trying to avoid? I mean, because Benda has now become basically the preferred treatment for follicular lymphoma. And if we're going to wipe out all their T cells, then that means that perhaps we should rethink this. Obviously, time helps to heal all wounds, shall we say?
Yeah, so I think definitely we need to look at not using bendamustine, especially up front, because the few patients that we tried to use the other bispecific on, we also saw that they had bendamustine in the months preceding. And when we discussed it with the experts that we had here, and she had said that at least 9 months, the bendamustine is actually active in the system for 9 months and that T cell depletion. So you need to be very careful when you're using it. So you should be using these therapies after 9 months to allow some sort of
Mm.
reconstitution of the T cell component.
Yeah. You didn't really touch on it very much, but you did explain the differences between sort of bispecifics, BiTEs, antibody drug conjugates, and even to some extent the radio labeled products. But I think we're very fond of cellular therapies here in Pretoria, but the allo transplants and CAR Ts are never going to really become accessible the way drugs like this can be, unless they can become in vivo. I mean, allo transplants for this toxicity reason and CAR Ts is, even if the price comes down, it's the logistics around collecting, manufacturing, and reinfusing the autologous nature of the product. Every time you have to treat somebody, you have to make a treatment for them. Whereas these are off the shelf, and I think there is some attraction on on this in terms of what you showed, the sort of long half-life, the on-shelf stability compared to the radio label products. I mean, the older people amongst us, and I don't see that many of you around, will remember a drug called Zevalin, which was actually a very effective drug, but the logistics around using radioactive products is always a little bit difficult. So something that is truly off the shelf, that is stable, that has an easy dosing schedule, I think is always going to be attractive. And once in 3 weeks, I mean, that's how we treat lymphomas, isn't it? So very encouraging. I don't know if there are any other. Um, Vernon remembers Evelyn too, and I plead the fifth on that question, Vernon. Did I have another question? Oh, you just made a very important point, I think, right in the beginning, is that when you have a relapsed follicular lymphoma, is that it behoves one to take a bit of time and make sure that they haven't transformed, because otherwise you're just using a low-grade therapy in a patient who needs something more intensive.
So there is a question here about if bone marrow studies are still required if you do PET-CT. So I would say yes.
I missed that. Okay.
We would
Yes.
definitely do a bone marrow to complete the staging.
Yeah.
And then the other question was, if the first line is BR, can we still use BR in the relapse setting? So we wouldn't do that. We'd opt for something else. And then conditioning in the autologous stem cell transplant for patients with follicular lymphoma. So we would use BEAM or ribomycin with etoposide and cytarabine and malphilan conditioning. And you asked about infection being due to So yes, infection is mostly due to hypogammaglobulinemia. So prophylactic IVIG should be used in these patients. And then the cost, which we don't know about yet. And then Sharok asked which is a very good suggestion actually, why is the IVIG not coming out of the blood product benefit instead of the oncology benefit? This is a good question. I'm not sure why it's not, but we'll to make some queries and see, because that would really help the patient's funds go further. And then Garrick asks about how would you time vaccination in this scenario with IVIG in the mix? That's interesting. So Garrick, what vaccination are you speaking about exactly?
I think just routine vaccination. So, if you're going to give someone, say, for example, pneumococcal vaccine, how would you, I know in CLL particularly, it's quite difficult, with vaccination. So I'm just thinking, in this instance, how do you approach vaccinations in patients with, immune therapies? Is there like a global approach? Yeah, just a basic approach.
I haven't seen anything on this actually.
But there's a rationale to say that if you're not making antibodies, then one has to be a little bit cautious about vaccinating, and that as soon as patients start to recover their immunoglobulin fraction is probably the time to vaccinate them. Also, to look at the prevalence of the conditions in your environment. So the pneumococcal vaccines, I think, are very important. RSV is becoming, accessible and an important infection in our patient population. So I think those are probably, and the annual flu vaccine one would encourage patients. We still struggling a little bit with the zoster vaccine because it's a live attenuated vaccine, although there is a DNA-based vaccine, but it's a two-part vaccine. It's not approved or licensed yet in South Africa, and you can get it on Section 21, but it's around about 5,000 Rand, if I'm not mistaken. So a little bit
Is that the
difficult.
Shingrix? That's the Shingrix
Yeah.
that we're speaking about, yeah.
So, well, I think with that, we can say thank you to Zinat. Thank you very much for a well-prepared talk and an interesting topic and very thought-provoking. a lot of people that stayed for a long time. We did break the 100 mark at some point. And thank you again to Roche and to Blood SA for the support and the platform that we get. And to everybody, again, to have a good holiday, and we'll see you on the 2nd of February. Thank you again, Zinat.
Thank you. Thanks, David. Bye.
Thanks, Zina. Thanks, David.
Thank you, Nicole.